2018.
Sorry.
No problem. And as you all know, the Community Behavioral Healthcare Association, or CBA, represents safety net mental health and substance use providers across the state who offer the full continuum of behavioral health services to thousands of children, adolescents, and adults daily. So thank you again for having me. So excited. As I was putting together these slides, it reminded me of all the amazing work and all the promise that this center will bring, right? And the opportunity to really help address in a comprehensive way the behavioral health workforce shortage. So as you all know, the behavioral health workforce shortage was already at dire levels before 2020, and it has only worsened since. The reasons behind the behavioral health shortage, as you all know, are varied and include too few people entering the profession, an aging workforce, overall lack of adequate funding, and comparatively low salaries. And the list now includes obviously all the dynamics brought forth by the pandemic. Obviously burnout is huge, competition, and people leaving the field altogether. If you, the slide 2.
Okay, let me pull it up for you. I'm gonna go ahead and share my screen here, so bear with me.
And as you bring up the slides, this is really in the context. Again, we started working on this initiative back in 2018, and I'll go through the background, right, of how this all began. So it's kind of via that perspective and the perspective of the behavioral health workforce education center task force, that it did a lot of the work in terms of the research and hearing from speakers, and I'm really developing the concept. And I'll talk about it. Our CBA CEO, Marvin Lindsay, and I were part of the task force, and Marvin actually was the chair of the task force. So in this slide, as you see, I kept some of the stats that we had in the report. That report was submitted to the General Assembly back in 2019. And again, the situation has only gotten worse, but you can see here from the Kaiser Foundation estimates that only 23.3% of Illinoisans' mental health needs can be met with its current workforce. We know that shortages are especially acute in rural and underserved urban areas. I did pull this more recent stat. A 2021 report by Mercer notes that by 2026, unfilled mental health care jobs in Illinois are expected to reach 8,353. And you see other data points that we had included. And I'm gonna read you an email that we received from one of our members recently. We get these all the time, and we have received them for years, really. But just this really talks to the gravity of the current situation since the pandemic began. So she said, if my team were fully staffed, there would be 8 people. After the most recent resignation, we are down to 5. At least two of those have been on the verge of quitting recently. They're not leaving because of the clients. They're leaving because they can make more money outside of the field. They're leaving because they are burnt out and exhausted from covering for staffing shortages in our program and from trying to help other teams that are even shorter staffed than ours. In the past month, I've had 1 applicant for all my open positions. And after hearing the salary I can offer, the individual declined to interview. And again, this is just one of many discussions and conversations we've had with our members and emails that we receive. And you want to go to the next slide? And here again, we know that when the supply of staff cannot accommodate the demand for services, are real consequences. Children, adults, and families in our community suffer. It can lead to an increase of worsening of symptoms, family conflict, or risk of suicide. In Illinois, nearly 1,000 individuals took their own lives in the first 3 quarters of 2020. Overdose deaths are skyrocketing. Our state has the 6th highest rate of suicide for Black youth in the nation. Black children under the age of 13 are more than twice as likely to die by suicide compared to their white peers. People with serious mental illness died 23 years early. As a result, individuals with mental health and substance use disorders end up, without services, without the capacity in the community, without that workforce. We know they end up in emergency hospital rooms, which are the most expensive level of care, as you all know, or incarcerated and do not receive adequate care, if any. So for our association, the number one priority for really a long time to help address the workforce and capacity issues has been to push for increased reimbursement rates via legislation. We have among the lowest reimbursement rates in the country. That push is going on really strongly this legislative session. And I can talk about that for a really long time as well, but we're to talk about workforce. But again, as you all know, workforce and rates are tied, go hand in hand. And we also know that the responsibility for the behavioral health workforce is dissipated among many different agencies. So no one agency or entity is responsible for workforce planning that is essential for other behavioral health reforms to succeed. So in doing our research and looking at what are other states doing to help address this in a comprehensive way, right? We tend to, put a Band-Aid on things, but we really wanted to address this issue in a comprehensive way so that, we have a strategy and that, year over year, we are indeed seeing improvements. So in doing our research, we came across the Behavioral Health Workforce Education Center of Nebraska. Their whole existence is to address the behavioral health shortage in Nebraska, particularly in rural and underserved areas of their state. For short, they call it Beacon. So Beacon's mission is to improve access to behavioral health in Nebraska by developing a skilled and passionate workforce. So we're going to share their overview video. That video really could have been made for Illinois and probably for most other states across the country, but this will really bring the vision of what we were seeking to do, what we're seeking to do in Illinois to life. So you can play the video, Jody, please.
Nebraska's behavioral and mental health care needs are changing as both rural and urban communities struggle to meet the diverse needs of the population.
So the Behavioral Health Education Center of Nebraska, or Beacon, as we call it, was created in 2009. And it really is what we hope to be the solution for the state's workforce challenges. The shortage of psychiatrists, nurse practitioners, PAs, psychologists, and other therapists really has made it hard for families to find access to good care, and we're trying to solve that. Beacon actually is a unique entity in that it's a partnership from many different groups. Its initial founding in 2009 really came from a conglomeration of several groups. So one was the academic medical centers, UNMC in Creighton. Second was government entities like Division of Behavioral Health. Third really is going to be community partnerships, strong philanthropists and others in the community who really care deeply about behavioral health. And finally, I would say that consumers and really the recovery movement really what helped inspire us as well.
Operating from the UNMC campus in a rural hub location at the University of Nebraska at Kearney, Beacon is dedicated to improving access to behavioral and mental health care across the state of Nebraska by developing and retaining a skilled and passionate workforce. This is being accomplished through four major areas of focus: recruitment, preparing and training the future workforce, training and retention of the current workforce, and providing workforce reports and evaluation. The Beacon Ambassador Program is a pipeline program designed to recruit students from high school, college, and beyond. The program provides opportunities to introduce students to behavioral health professions and connects them with mentors and programs to encourage further exploration of these careers.
This program will develop such a great group of people that are going to work together in the future to, really focus on behavioral health issues.
Beacon maintains a pipeline of students training in psychiatry, psychology, marriage and family therapy, and counseling. It does this by supporting psychiatric residency programs, establishing interprofessional clinical training sites, and supervising clinical internships with primary care clinics, community agencies, and hospitals, especially in rural and underserved areas.
We really try to foster the development of our students into professionals. And the way that we do that is to, once again, provide that high level of supervision, but also we want to provide them with support beyond their training year.
Beacon is committed to interprofessional behavior health training and curriculum development for practitioners and trainees across the state of Nebraska by offering webinars, online learning modules, conferences, and in-person training.
And what we're really hoping to do is to find policymakers, educators, and frontline clinicians to really think about the workforce we need for the future and what the best solutions are.
To connect behavioral health employers with job seekers in the state, Beacon collaborated with Region 5 Systems to launch NebraskaBehavioralHealthJobs.com. The site, which is made possible with the support of both private and state funding, is free for employers to post jobs and free for job seekers to search for jobs. Beacon partners with UNMC's College of Public Health to offer two important resources: the Nebraska Behavioral Health Workforce Analysis, which is published every 2 years and provides an in-depth analysis of the current supply of licensed behavioral health professionals in the state, and the Nebraska Behavioral Health Workforce Dashboard, an interactive online tool designed to illustrate current behavioral health workforce distribution. Beacon's approach to addressing Nebraska's behavioral and mental health care access needs is already paying dividends.
It is great to have a psychologist here in the office with us where we can introduce her to our patients the same day I see them. The patients really like it because it takes a lot of the stigma away that they're afraid of. With primary care, the really nice thing is that instead of saying, let's make 3 appointments on 3 separate days, so really being able to say you can have all the different types of services you need for your family right now in this one location. Working with Beacon has really helped me focus more on the dire need for mental health services in the rest of the state.
Ultimately, while Beacon is already making tremendous gains in addressing the state's behavioral and mental health care crisis, there is still much work to be done.
If Beacon didn't exist, I think we'd still be stuck in the old model of practice, which is that any one of us, whether I'm a psychiatrist or a counselor, would still see one patient at a time. What we hope to see, and we're starting to see movement on, is population health. And that just means that any one provider really can extend their impact to dozens, hundreds, and maybe over the course of their career, thousands of families.
As I look forward to how I plan to practice someday, and even I think about how important it will be to have people who are trained at all levels of behavioral health in order to make that practical. And some of those people might be able to work remotely, and some of those people are going to have to be in those communities to provide on-the-ground care for people who need it. And I'm hopeful that I'll be able to try to find those people that I need to work with, because Beacon's been really in the groundwork for years now to help people see the opportunities in the field of behavioral health. I'm hopeful that I'll be able to find those people that I need them to provide the kind of care I want to provide for patients.
Drinking water before
Okay, sorry here. Get my back to the, there we go. Okay, is this the slide you were on?
Yeah, if you can just, and I'll get to that. I just wanted to share some, so as you heard per statute, Beacon is required to provide reports to their General Assembly every 2 years. And I just wanted to share some of the data that, or some of the highlights from that report, because it really does, again, there's a lot of work to be done still across the country and for Beacon, even though they did start this back in 2019, but they are seeing improvements when, again, the majority of the country, including our state, is seeing these dire level shortages. They're actually seeing some improvement and some traction in helping to build up their behavioral health workforce. So from 2010 to 2020, the supply of their behavioral health workforce providers has increased by 32% among psychiatric prescribers and 39% among psychologists and mental health therapists. More than 5,189 students in Nebraska have learned about their careers in behavioral health since 2010, and that's through their ambassador program. Beacon has strengthened partnerships with 18 academic institutions providing graduate and doctoral behavioral health education in the state to collaborate on training and workforce retention. And then Beacon provided professional training for more than 4,914 individuals during fiscal year 2021. And there's just a lot of really amazing things that are shown in that report. But I just wanted to give you some background in terms of, again, sort of the progress that has been made, and again, sort of the inspiration to the creation of something similar here in the state of Illinois. So just as background, so that was really, again, the inspiration. And then after, we came across that, we started talking about how can we bring something like this to Illinois because of its promise to really help, again, address our situation in a comprehensive way. So again, during the 2018 legislative session, a bipartisan group of legislators at that time led by Lou Lang, who's no longer, in Springfield, and Tom Demmer, a Democrat and a Republican, they sponsored House Resolution 711, which declared that Illinois is suffering from a behavioral health workforce emergency. The resolution declaring a workforce emergency was unanimously adopted in the House. That resolution was followed by legislation, which passed unanimously in both chambers and was signed into law. And this creating the Behavioral Health Workforce Education Center Task Force. And again, this task force would be looking at, developing a similar model as the Nebraska model here in the state of Illinois. And again, the key motivating factors for the creation of the Illinois Behavioral Health Workforce Education Task Force included, again, the insufficient number of behavioral health professionals in the state, the absence of an action plan on behavioral health workforce development, inadequate training and evidence-based practices, and the resulting restrictions on access to high-quality community-based healthcare services. Again, as I had mentioned, the task force was chaired by Marvin Lindsay, our CEBA CEO. I was part of the task force, but the task force also included folks from the University of Illinois Chicago Hospital and Health Sciences System, Southern Illinois University, Lurie Children's Hospital, director at that time, Diana Kanabi, who was the director of the Division of Mental Health. We had folks from the Jane Addams College of Social Work at the University of Chicago. We had the Illinois Student Assistance, Illinois Higher Ed was also part. They actually helped facilitate all these meetings and were supporting the task force in this way. But really, a lot of really amazing folks were part of this task force and really contributed to making this, really come to life. If you want to go on to the slide 6, the next slide. So the task force charge. So the charge was to study the concepts presented in House Bill 5111, creating the center, the Behavioral Health Workforce Education Center, inspired by the Nebraska by Beacon, gather data, receive stakeholder input, consider the fiscal means, right? Very important, by which the General Assembly might most effectively fund implementation of the concepts presented in House Bill 5111, and then submit the findings and recommendations to the General Assembly on or before December 31st of 2019. Next slide. So the information gathering, the task force met for almost a year, from November 16th, 2018 to December 12th, 2019. We held monthly video conference meetings, sometimes in-person meetings, received input from diverse group of stakeholders, examined data, collected and discussed strategies and recommendations. So a lot of work went into that, a lot of work. It was a very busy time, but very exciting time to do this research and talk to so many folks who, who basically shared, our concerns and the challenges with the workforce. The next slide. Which one is this one? Okay, and as you all saw, so the behavioral health workforce, it was very important, right? Because when you talk behavioral health workforce, it's very diverse, and we want to make sure that who we were talking about was very clear, especially as we were having these conversations with legislators. So we did note that the behavioral health workforce includes, but is not limited to, social workers, licensed clinical social workers, counselors, marriage and family therapists, clinical psychologists, substance use disorder counselors, peer support specialists, and the prevention professionals as well. So we wanted to make sure that was clearly noted. Next slide. So I kept this testimonial from back in 2019, these testimonials back in 2019 in the slide deck, because again, the situation even at that time was very, very serious. So again, this has only gotten worse. One of our members, we have had no applicants for clinical positions who have possessed a master's degree or license since 2018. In 2019, we have only been able to hire individuals with bachelor's degrees and no experience or minimal experience to fill clinical positions. Back in 2018, 2019, we were really talking a lot about it. With the shortage was especially acute, and it still is, right, with clinical professionals, so licensed staff. We know that situation, because of COVID or since COVID, is across the board. So it's across the board with every staffing level within agencies. So that's why I wanted to include this slide. But you want to move on to the next one, please? So two of the is this the next slide? Yep. There you go. So two of the main challenges to confronting the workforce crisis in Illinois identified by the task force. So one was workforce data collection. Our workforce data collection was not equipped for workforce planning and development. The task force did request, we requested and received counts of behavioral health professionals by county from IDFPR. So while the data did give a rough indication of where licensed professionals made practice, there were major weaknesses in the databases as a workforce planning tool. For example, licensed physicians are not reported by specialty. So specific counts of psychiatrists by county are not possible, nor accounts of crucial subspecialists such as child and adolescent psychiatrists or geriatric psychiatrists. A professional with a license is not necessarily a practicing clinician, and the licensure database records active licensees, but cannot report whether a licensee is practicing. And then the licensure database also do not collect information on demographic characteristics, obviously, that are important for people seeking services, such as languages spoken, race, and ethnicity. One notable weakness in the data set on the behavioral health supply is that none of them were built for purpose of workforce planning and are really maintained to enforce licensure and certification rules. And the Medicaid provider data are designed more for oversight of state contracts than for monitoring trends and needs in the overall behavioral health workforce. So again, as I had mentioned, the responsibility for workforce is dissipated among many different agencies, with no one entity responsible for workforce planning that is essential for, again, other reforms to succeed. So those were some of the findings of the included in the report. Next slide. So after many presentations, research, and data collection, the task force began developing the structure for the Behavioral Health Workforce Education Center. The center would be responsible for developing and implementing a strategic plan for the recruitment, education, and retention of a qualified, diverse, and evolving behavioral health workforce in the state of Illinois. Next slide. And then, so the structure of the center. So the center is structured as a multi-site model, and we called it in the legislation a hub and spoke model. So the administrating institution will serve as the hub institution, and that's going to be complemented by secondary regional hubs. That would also be academic institutions that serve rural, and small urban areas, and at least one academic institution in the Chicago area. That was really important, to do this and to ensure that there wasn't just, one area of focus, of course, because we know that the challenges, obviously there are similar challenges across the state, but we know that communities face very unique challenges, right? And we wanted to ensure that there was representation and that the planning took into account those sort of variances, within the different areas of our state. But as I mentioned, the center will be located in one academic institution and will have the responsibility of convening and coordinating workforce research and planning, including monitoring progress towards the center goals. The center will coordinate with key state agencies involved in behavioral health workforce development in higher ed in order to leverage disparate resources from healthcare, workforce, and economic development programs in Illinois government. Next slide. Some of the center duties include organize a consortium of universities in partnership with providers, school districts, law enforcement, consumer groups and their families, state agencies, and other stakeholders to implement workforce development concepts and strategies in every region of the state. As you all saw in the Nebraska model, they really brought all these different stakeholders to the table. And we know the value in ensuring that there is that sort of diverse representation. So we wanted to take that model and also implement it here in the state of Illinois. The center will also be responsible for developing and implementing a strategic plan for the recruitment, education, and retention of a qualified, diverse, and evolving behavioral health workforce in the state of Illinois. The state of Illinois, and I'm going to mention, did issue an RFI, and so this piece is and I'd be more than happy to share that, but this piece includes a lot of other different responsibilities. And actually, I will go over some of them because it's a really amazing model. So they're going to be charged with some of the planning activities under this responsibility for developing and implementing the strategic plan is convening and organizing vested stakeholders in the planning, and again, including all the various stakeholders that I had mentioned, collecting and analyzing data on the behavioral health workforce in our state with detailed information on specialties, credentials, additional qualifications such as training and experience in particular models of care, location of practice. Very important, right? And demographic characteristics, including age, gender, race, and ethnicity, and languages spoken. And again, building partnerships with school districts, public institutions of higher ed, and workforce investment agencies to create pipelines to behavioral health careers from high school and colleges, which is again also modeled after that language was also modeled after the after Nebraska and their ambassador program. And then again, the data collection and analysis piece, which is critical, and then working to grow and advance peer and care and PO workforce development, focus on the training of behavioral health professionals in telehealth techniques. And then the final responsibility, prepare behavioral health workforce reports and analysis, similar to what Beacon is required to do every 2 years. Next slide. So what happened next, right? So we went to our legislators. We have this, task force met. We have, developed what, our thoughts, based on all the information that we have gathered and all the testimony and all of that. We have developed this concept that could, be a good model for Illinois. So we went to our legislators to make this happen. And at that time, Senator Heather Staines, who's no longer a state legislator, and Representative Robin Gable sponsored legislation back in 2018 to establish the Behavioral Health Workforce Education Center of Illinois. In 2021, that legislation did not move at that time, but in 2021, Senator Fine did. She refiled the exact same language because this was a very new model. And again, at that time, the workforce shortage for behavioral health has always been a significant issue. We've been talking about it with legislators in hearings for a really long time. but it hadn't resonated, right? And again, I think because of COVID, all this, it's at the forefront and it's on everyone's mind. So it really got traction last year in 2021. This legislation, it was filed by Senator Fine, but ultimately got included in House Bill 158, which was a Black Caucus healthcare pillar. So we were very, very excited that our legislative language was included in that bill. As you all know, that bill passed and is law. And SIBA also advocated for funding. The report recommended a $6 million investment that is going to be fully funded. We were very grateful to our state legislators and to our state agencies for committing to fully funding the Behavioral Health Workforce Center. So it will be funded at $6 million. Next slide. So in July 2021, the Board of Higher Ed issued an RFI to all public institutions of higher ed in partnership with the Division of Mental Health, selected the University of Southern Illinois and the University of Illinois. So they will be leading the efforts now. I feel like I just gave them my baby. It's been such a amazing work, and we just love this entire experience. So now we are passing it on to them to make this all come to life, and are very excited. We were able to see, a little bit of sort of what they envisioned, right? We set the framework for what we thought this could be, but I'm sure they're, going to make it so much bring this to life, and it's going to be so much better than we can even anticipate. So I have all the faith in the world that that's going to happen. The center is scheduled to launch before the end of calendar year 2022 or in the first quarter of 2023. So extremely excited to see all this work come to fruition and really see us, right, our state moving in the right direction and really addressing the behavioral health workforce shortage in a comprehensive way. And again, that will include race, and it's something that we are we have active legislation to address our behavioral health rates, and doing everything else that Nebraska is doing, and was included to an extent, and again, and of course tailored to address our issues in the state of Illinois. So very excited about the prospects of the center, and hopefully seeing improvements. So a couple of years down the road, or 3, 4, 5 years down the road, we're actually seeing gains as opposed to where we currently are, which is in the same boat as the majority of the country. So that is my presentation, and I'd love to take any questions.
If anybody has questions, you can post it in the chat box, or if you want to raise a hand, whichever.
If you don't have any questions, I would really love to get your thoughts. And I'm sure a lot of you followed this, through the, we've been talking about it for so long, have been hearing about this in different hearings. So it is not necessarily a new concept. But if there are no questions, I would love to hear your thoughts about sort of, the product, right? And of course, once, the universities, take over, we'll see, what happens. And again, I have all the faith in the world, because, that we're going to see an amazing product come to life. But any thoughts and just sort of the promise of this? Or
I think we've got Chandra, raise your hand. I think you're on mute, Chandra. Here we go.
Oh,
Here we go.
yeah, I just have a question. Will the money for the behavioral health, like retention, of course, is for recruitment, but will this also help with tuition assistance? A lot of times, a barrier for a lot of younger people is, and people to go into the field, is student loans.
yes.
Because of the barriers that have been put in place for a lot of people to attend college. Financial aid is limited to a certain time frame. Student loans are limited, and then also parents' income have been utilized as well. And if they are making too much money, the student isn't allowed to like file independently. So I'm just curious to know, would this help with tuition assistance as well?
Yes. So what we did, so we actually, back in 2018, SEBA filed legislation actually passed creating the behavioral health professional loan repayment program. That will finally be funded this year. So the loan repayment program, because we were thinking, obviously this, we were talking about short-term and long-term solutions, right? We know the center is a long-term sort of solution, and we're trying to address this in a comprehensive way. So it's going to take time. We're not going to see, the fruits of all of this work in the next year or 2 years, right? So we wanted to make sure that we had other ideas. So that was one of them, right? And that behavioral health professional loan repayment program will be live in May of this year. We'll go live in May of 2022, and DMH will be investing $5 million in the program.
Nice. Oh, go ahead. I'm sorry.
No, I was gonna say, but Beacon does do. Well, I'm hearing my echo. Are you?
Feedback, I think.
Yeah. I was gonna say, so, but Beacon does do some similar things, right? They have different initiatives that we're working on. That they're working on. They do file legislation. So they do work. Whatever strategies they come up with, and they identify a need. They do file legislation for funding for different things, right? In the report, and I'd be happy to share their most recent report talking about the different legislative measures that they push. But some of them are funding requests for things like, loan repayment, stipends, and things like that.
Thank you.
Thank you. Oh, I'm sorry. I think we had Amy or Ron. I was going to say. Go ahead, Ron.
Amy, you can go first.
Okay, I'll try to be brief. Thank you, Ron.
Okay.
I think I know most of you. I'm Amy Stern with the Illinois Children's Healthcare Foundation, and I actually was just thinking I have no idea how I got on this meeting of ACMHAI, other than that it's a topic that we care deeply about. So one of the things that we've been thinking about, as with everyone else, very concerned about the children's mental health workforce in particular, is how did we get here? So what's happened systemically that we're here now? And so one of the things we've been really thinking about is that back when, like in 2009, when the mental health system went from grant funding to fee-for-service funding, the community mental health providers, which really were kind of the training ground for all of the mental health disciplines, from psychiatry to social work to nursing, I mean, all of them. And they were able to provide really excellent supervision and training and mentorship that I think a lot of us got our clinical chops from, working in those situations. And the community mental health agencies just cannot afford to do that anymore under the fee-for-service model. So as funders, one of the things we're looking at is thinking about how can we, from philanthropy, pilot some shorter term, quicker interventions that can perhaps put some resources back out there into the community mental health agencies to help bolster some of those resources. And it struck me as I'm listening to your conversation that may also be a position that the 708 board partners could do as well. So a couple of things that we're doing, or we're in the process of doing, is funding College of Social Work to enroll a diverse set of MSW students and support them through tuition and a $10,000 stipend, and specialized training in evidence-based child and adolescent mental health care, which, Ron, should sound familiar to you in terms of what your daughter's engaged in. But we're going to pilot that. We've got another foundation partner that is looking at doing that. And then the other piece that we're just starting to develop is working with a trade association to fund community mental health agencies to be able to provide stipends to a diverse array of mental health interns that are in their settings. And then also to fund them really to cover the supervision time of the LPHA staff, the master's level staff that are really in the best position to train and support the development of the mental health workforce. So we think that ultimately, if this works, it's something ultimately that government is going to have to take over, that it's, philanthropy is just not big enough to be able to do this. But there may be some opportunities within each of the 708 boards to kind of look at what can we do to sort of bolster the agencies in the meantime. And I think the focus on fee for service is just not working. It's everything is just deteriorating. And I don't know what you're hearing from your grantees, but our grantees aren't able to hire people to do the work. They're closing admissions. And really, it feels like the mental health workforce is imploding. And it's terrifying in terms of what it means to the citizens that we care so much about.
Amy, I fully agree with you. In fact, I was at a meeting at Proviso Township Mental Health Commission last month that they announced, Jesse Rosas is their executive director, and he announced that they are no longer doing the purchase of service. They are switching back to grants. And he apologized for the bureaucratic burden that purchase of service has been. And they're moving forward with developing a new grant program in their grant application process right now. It'd be wonderful if the state would do that as well. I mean, our mental health commission moved only a few of our contracts into purchase of service where it made sense, and most of them have been grants, and the agencies have been very grateful for that over the COVID crisis. Amy, Blanca, you both know how I've expressed myself regarding what do we do in the short term, as far as licensing and things like that. In this hub, are they also working with the career centers at the university and the alumni groups and the newsletters to alumni and things to try and bring people back into the field? Or if someone's looking for a position, maybe they've got an MSW, but they've decided to do something else, and how do we draw them back if rates are going up, if funding is a little more available, if things are more supportive? How does this hub work with the university career centers and those who are just graduating or have already graduating but may be redoing their resume because they're looking for a new position, now that things might have changed in their lives 5 years after they've been in the university, or 10 years after they've been in the university, et cetera.
Yeah, so this center will be operational hopefully at the end of the year or early 2023. So it is not yet operational. Mm-hmm. But that's part of it, right? Part of the recruiting and retaining process would be a part of all of what you just said would be part of the discussions, and hopefully would make it onto the ultimate a strategic plan that they develop. So yeah, so I would think it would be, right, and I'm sure, I can't imagine that wouldn't be. It's just sort of your basic recruiting, but again, the center is not operational, so I really can't say for sure. But the one thing was that we didn't want to reinvent the wheel, right? We know a lot of amazing work is happening across the state. So some of that is probably already happening, Ron, within the different universities, potentially. But we don't have that information because everything, all the work that is happening is, just, disparate. There's no coordination. And of course, it's going to take will, and it's going to take, a lot of conversations to bring all these groups together. But I think the issue is at a point, it's at a crisis point where I think, the folks who really want to make a difference are indeed going to come to the table and have, those discussions that are needed to be had, and really work together to ensure that we can move, forward in the right direction on this issue. So I'm hopeful.
Me too.
Anyone else? Go ahead, Dana.
Yeah, I just wanted to follow up on a little bit of what Amy and Ron had discussed, and Jesse's revelation that he was actually a problem for people. Yeah, I think it's popular now to say, let's abandon the fee for service, but as an advocate of fee for service in some instances, I think we have to remember that we're stewards of local tax dollars, and the fee for service was a mechanism where monthly you had to take a look at what people were performing so you could reimburse them. That's not a bad process for monitoring. If we go with a grant, and much like DMH at this point, have little contact with our providers, we're failing in our responsibility to be those stewards of tax dollars. So I'm okay with, and I give a lot of money out as grants as well, but I think there needs to be an acknowledgement that there needs to be monitoring of those services, moving forward, and not simply a blank check.
Yeah. And I fully agree with you. We have monthly reports, we have quarterly statistical reports our agencies have to do. We have some that are purchase of service, many that are grant. Jesse, I think, was a unique situation where he was trying to form one of his own, almost an insurance company under those 5 or 6 models that Quinn had come out with, and then Rauner was moving into, and so you walked into that mental health board, and they had a whole billing department like an insurance company would, that task was providing. So I think his was a unique situation. Yes, you definitely need your monthly reports, your quarterly reports, your site visits, the oversight. You can't just hand them a monthly or a yearly check and just assume that everything is going well.
One other comment for Blanca, we locally are funding reflective supervision with someone from St. Louis University who's working with the therapist to kind of keep them patched up and going, especially in situations where there are smaller staffs or they're non-traditional providers where they may be a standalone therapist within an agency. So he's from St. Louis University. I'm glad to hear that the university, Illinois and SIU will be involved, because I'd like to let them know that service has been offered on a local level at a very minimal cost. I pay $75 an hour. There's even some group work as part of that. So we do have a way of trying to address some of those, critical workforce issues by pulling together what we can locally and using someone who has that capacity, although he's probably an island in doing this. So if it could be part of the work of the universities, that probably would be good moving forward.
Yeah, those are exactly the kind of work, right? That's exactly the kind of work that I'm referring to. You already have some, programs or initiatives established across the state. So how can we help support that? How can we reinforce that? I didn't mention in terms of the funding piece, we did ask for state appropriation, obviously, to stand up the center, but really with the Nebraska model, they get the majority of the funding from federal government and from private foundations. So the legislation also calls for the center to solicit, to federal money and leverage federal money, which again, there's a lot of federal money out there, especially right now for workforce, and then leveraging foundation and those partnerships, private partnerships. But there's already good work happening. How can we coordinate that? How can we help support existing programs that are working? So that really is part of the vision.
Any other thoughts or questions from anyone?
Great presentation. Thank you.
Thank
Yes,
you. I'm excited that once this becomes operational, that we can invite, so Dr. Wolf, who was also part of, she's from a psychiatrist out of SIU. And then we had there were a lot of really just amazing, talented, very intelligent people as part of the workforce. Two of the universities, as I mentioned, and they had folks on that also, had some of planning, who help support the planning, that are going to be, again, sort of leading this effort now. We passed it on to them. It hurts my heart, but I'm very excited too, and see how we can all support now that it's in sort of this different phase. But I would love maybe, next time, Jody, when the center does become operational, you can sort of follow it up with inviting them and seeing, this is, we've taken this on, this is sort of now our vision and how we're going to bring to life that legislative language in the vision of the task force, to really, again, move us in a better direction in terms of our workforce. So super excited about the prospects and then connecting with those folks who I've given my baby to. That's what it feels like.
Well, thank you so much. We appreciate it. It's been very informative, and we'll share. And if you have any follow-up information, I think you mentioned the strategic plan or something like that. If you have anything that you want to share, I'll send that along to the membership. But thank you so much, Blanca.
The strategic plan is a charge of the center. So once that is the center and everything's established, then they're charged with creating that.
Okay, got it. Great. Okay.
Yes,
Well,
thank you.
Thank you all. Have a good one. Bye-bye.
Mhm.
Okay, bye-bye.
Bye now.
Thank you so much.
Mhm.